Hello, everyone.
Hi, Dr. Shea. Can you hear me? This is Paul. RAMPHAL.
Yeah, I can hear you. 6:30 on the dot, but let's give people maybe 3-4 minutes. Is it okay with you?
Yeah, I came down to this Cancer Society itself to give it because my wife.
Yeah, Aaron told me. Yeah.
Yeah. So.
Having a party down there, I think.
Yeah, we had a little bit of a time getting set up.
Okay. Your internet at home is no good.
It seems to be a little bit funny.
Erratic. Same with us here too.
Yeah.
How are you doing?
I'm good.
Great.
Can you see me?
As you know, October was a very busy month for us. And as Erin said, we were pretty busy around town on the airwaves and in-person meetings at some point. And we did get a lot of donations for the month, and I thank corporate Bahamas and all the donors for those donations. As you may or may not see, we having some renovations going on at the Cancer Society, so we're gonna have a good-looking building in several weeks. But want to welcome everybody to come by and see what we're at. We're 2 doors south of ZNS, and come and visit us, and we can give you a tour as well. In terms of announcements, I don't really have much announcements. We're still winding down this, well, not winding down, but still in this COVID pandemic. But hopefully the numbers will go down more and we'll get back to more semblance of normal. But we still need to practice social distancing and hand hygiene and all the stuff that we need to do to prevent COVID. So, as mentioned, the month of November is pancreatic and lung cancer, as well as carcinoid tumor month. But this year we're gonna have a talk on lung cancer. Dr. Paul RAMPHAL has graciously accepted to give the talk tonight. And Dr. RAMPHAL is a colleague of mine in the Department of Surgery. He is originally from Jamaica, or Canada, as he said. He did his medical school in Jamaica and did his DM training in cardiothoracic surgery in Jamaica as well. He was the senior lecturer in surgery in Kingston and head of the division of cardiothoracic surgeon at the University Hospital in Kingston. Presently, he's been in the Bahamas since 2007 and has worked in the Princess Margaret Hospital and Doctors Hospital since then. And he's done an yeoman's job working there. He is widely recognized and has lots of published papers, and he's belonged to many societies. He's married with 2 boys, and one of which is listening in tonight, I guess, from Toronto. So, Dr. RAMPHAL, I'll give you the floor, and you can go ahead and give your talk on lung cancer. And I thank you.
Okay, thanks, Dr. Shea. I appreciate that. Everybody's hearing me okay? And everybody can see my screen. First slide says lung cancer, what you need to know.
Yes, we can see it.
Okay, great. So believe it or not, with this seemingly never-ending pandemic situation, despite the fact that lung cancer is a horrendous condition and it causes a lot of misery in the world and in our own backyard, it is somewhat of a relief not to have to listen to or talk about COVID tonight. So with some relief as a thoracic surgeon, I'm happy to come and help you understand a little bit about lung cancer and what we as a society and people need to know about lung cancer. And so we'll just get going. What we're going to, what we're going to be talking about are things like how common lung cancer is, what really it makes up lung cancer, the types of lung cancer, the causes, of course, is very important to discuss because most lung cancers are potentially avoidable conditions because most lung cancer is due to or associated with bad habits that we'll get to and talk about. Specifically, one major bad habit. And I think everybody is going to be able to guess what that is before we even talk about it. But there are also risk factors to development of lung cancer that we can discuss. Some are modifiable, some are not modifiable. And as a result, there are probably a majority of lung cancers could have been prevented if people had avoided some of these risk factors. And so if you learn about them, maybe you or your family members can avoid contracting this horrendous form of cancer. And then we're going to talk a little bit about ways we can screen for lung cancer, why we should screen and who we should screen for lung cancer. And again, to reemphasize things you as the public can do to protect yourself as much as possible from developing this form of cancer. So lung cancer is a very common form of cancer. In men, it's only second to prostate, and women only second to breast. As a result of that, it is the most common cancer overall because it is second in both categories. So for male and female, it is a very common form of cancer. Probably about a quarter of all cancer diagnoses are lung cancers, and we're talking about primary lung cancers, and I'll explain that in a second. But lung cancer mainly occurs in people after their mid-40s. And of course, for smokers, and this is the bad habit I will come back to many, many times during this talk, the risk of developing lung cancer is much, much higher than the average person. It's the leading cause of cancer death in men and women in USA and Europe. And in many cases, those are where our statistics will be coming from, because those parts of the world tend to keep their statistics in the most comprehensive fashion. So we often refer to European and North American statistical analyses of disease processes like cancer because of the wealth of data that they have. Now, the exact correlation between the American or European situation and our local situation may not be one-to-one, but it's close enough that we can infer a lot about what goes on with diseases like lung cancer from the European and North American data. And about a quarter of all cancer deaths each year are due to primary lung cancer. Now, when I say primary lung cancer, I'm talking about cancer which has originated in the tissues of the lung, as opposed to other forms of cancer which may spread to involve the lung tissue. Those are known as metastatic cancers or as secondary lung cancers. And we're not speaking about those per se. Those are really other cancers, such as breast, such as prostate, such as bone, such as liver, such as colonic, etc., cancers, which can involve the lungs in many situations. But that's not primary lung cancer. We're speaking of lung cancer that originates from the tissues of the lung itself and not from other parts of the body that spread to the lungs. And to understand lung cancer, we should always go back to what the lungs are and what they work, what they do, how they work. And of course, the lungs are very large organs from a point of view of how much space they occupy. Each lung occupies half of the chest cavity, and the lungs are two sponge-like organs that are found in the chest cavity. When you breathe in, the air will enter through the tubular airways, and the air will be travel along the airways in a branch-like pattern. Think of the airways as a hollowed out tree in a way, where the main airway, which is known as a trachea, which is here, splits into two, left and a right bronchus, and they continue to split and divide until they get microscopic in size, and that carries the air all the way into the deep tissues of the lung, where it gets into other structures known as alveoli. These are like little sacs at the ends of the airway. And if you look here in this drawing, you'll see these sac-like structures. These are microscopic structures in the lung, and they are very close to the blood flowing in the lung. And as a result, gases like oxygen and carbon dioxide can diffuse in and out of the bloodstream through the lungs. And that's really the main function of the lungs, to put oxygen into the blood and to get the carbon dioxide, which is a waste product of metabolism, expelled from the body. And that's what the lungs do. Now, there are two types of lung cancer that are really of any significance from a clinical point of view. One is called small cell lung cancer, and it's a really aggressive form of lung cancer that spreads from the lungs very early, involves the brain and the bone and other tissues, the liver, etc., very early in its course, often before the primary tumor can even be detected, you may end up having metastatic deposits in other parts of the body, such as the brain and liver and the bone. And so small cell lung cancer is a really terrible form of lung cancer. And the other one is known as non-small cell, which is composed of a number of different subtypes. And it is a terrible cancer, though not as quick to metastasize as small cell lung cancer. And it is the majority of lung cancers are non-small cell, which means that they tend not to spread from the lungs, in other words, become an advanced form of cancer before they are actually detectable within the lungs. And that's a good thing. If you can look for them and discover them, you might be able to intervene with a combination of surgery and chemotherapy and radiation therapy and potentially cure a non-small cell lung cancer. In other words, remove it and destroy it before it spreads to other parts of the body. As everybody who is associated with the Cancer Society probably knows, but the general public may not be aware, when a cancer spreads from its tissue of origin, in other words, when it becomes metastatic and when it becomes advanced, as opposed to an early cancer, which is when it's confined to its initial tissue of origin. When it becomes advanced or metastatic, it is not curable in the absolute sense. It may be controllable. We may be able to give drugs that slow down its growth and add many years, especially in the modern era, to a person's life. But in terms of eradication of the cancer, once it spreads from its original tissue to other tissues of the body, it is generally not curable. So it's a good thing that most lung cancers are of the non-small cell type, which tend to metastasize later in its course, which means we have a better chance if we detect it early, when it is small and has not started to metastasize. We have a much better chance of curing such a cancer if we can discover it. And some lung cancers have mixed properties between the non-small cell and the small cell. Those are not very common, thankfully, because it's hard to figure out what to do with such a tumor. And of course, the pathologist will have a way of recognizing the various types of lung cancer when they look at them under the microscope. And of course, the small cell lung cancer on the left of this screen is actually a higher magnification than the views on the right. So the small cells look bigger than the non-small cells. That's just a feature of these two slides. But the small cell has much less of a pattern that resembles the original lung tissue than does the various types of non-small cell. And this is more than the average public needs to know. But just for you to realize that these diagnoses would be made classically on the microscopic appearance of the tumor, but even more recently on other ways of analyzing tumor with immunology and what's called immunohistochemistry techniques, and genetic analysis can give us even more information than the tried and true looking at it under the microscope can. So the specific delineation of what type of cancer that person has become much more sophisticated in the last 2 decades compared to, even at the turn of the century. These are images taken from post-mortem examinations of people who obviously passed with lung cancer, and showing the cancer. And is my cursor visible on the screen? Are you seeing the green cursor?
Yes, yes.
Okay, great. So I'm circling the area here in the left lung, which has been sectioned. This whitish area is the cancer. In this area here, in this specimen here is the cancer. In this specimen, this is an example of multifocal cancer, lung cancer, where it probably originated somewhere in here and has spread within the lung to multiple sites in the lung. However, metastatic cancer from other sites can resemble this pattern. So it would require certain special tests to determine whether this was a primary cancer that spread within the same lung or spread from another type of cancer to the lung. And here again is a primary lung cancer. And you can see how horrendously awful they look and how almost like an alien invading the body. However, let's remember that cancer is really the patient's own tissue that has lost control of itself. And instead of knowing when to stop dividing, their own cells continue to divide in an unregulated fashion. That's what cancer is. So although this looks like an alien invading the normal lung, and this pinkish purplish tissue here, and this pinkish tissue here, that's normal lung, but this is the abnormal tissue. It looks like an alien invader. It actually originated within the patient's own cells themselves. Something went wrong and has caused these cells to replicate and divide and multiply in a totally unregulated fashion, leading to this condition and disease. And that's what happens in all cancers in one way or another. Now, what are the causes of lung cancer? Well, most lung cancer, the vast majority, can be linked to smoking. Even if you yourself do not smoke, but if you're exposed for many years to secondhand smoking, we now know that this can cause the development of cancer. What needs to be present is this environmental trigger, or the cigarette smoke, and really it is chemicals that are in the cigarette smoke that are caused by the combustion, the burning of the plant material, the tobacco leaf. When that tobacco leaf is burned, the heat causes the release of a number of what are known as carcinogens, or agents, chemical agents that are known to be able to induce normal looking cells to become cancer cells. And those normal cells, while they look normal, they probably have to have a genetic tendency to switch to a cancer cell when exposed to something like the carcinogens in cigarette smoke. There are other less common or associated causes of cancer, and there are a small percentage of people who develop lung cancer who have no apparent risk factors. They're non-smokers, and they're not exposed to some of the other things we're just about to talk about. They just don't seem to have any risk factors, yet they develop lung cancer. And I have to say that when that happens to somebody, when somebody develops lung cancer who is not a smoker, who has not been exposed to secondhand cigarette smoke, for example, who doesn't work in radiation related occupations, or is not exposed to asbestos, etc. The cancer that develops in that person's lung is often much more aggressive. And therefore, we believe that those cancers are mostly due to genetic causes that we haven't fully delineated yet. Some of these cancers appear to be related to certain genetic mutations. But we find that when somebody develops lung cancer without a history of smoking, for example, that cancer is often very much more aggressive than the lung cancer associated with smoking, which is a really bad deal because lung cancer is already an aggressive situation. Lung cancer risk factors are anything that can increase or sometimes decrease a person's chance of getting a disease such as cancer. And risk factors are those. There are many known risk factors for lung cancer. We can change some, and some we can't change. But smoking, as I said, and I'll say it over and over, smoking is the leading risk factor for lung cancer. Smoking is entirely preventable. Smoking is entirely avoidable. Smoking has no benefit to your body in any shape or form. The tobacco smoking population will tell you, oh, they needed to do this, they needed to feel confident. They need it to feel relaxed. They need it to cut their appetite. They need it for all kind of things. Nobody needs smoking. Smoking is absolutely bad in all respects. Not only does it increase the risk of lung cancer developing, it also increased the risks of almost every known type of cancer. Certainly pancreatic cancer, stomach cancer, colon cancer, liver cancer, brain cancer, head and neck cancer. All of these types of cancers are absolutely known to be increased in smokers. And if smoking doesn't cause cancer in you, it will cause emphysema. And if it's emphysema is a disease that affects your ability to breathe and to put oxygen into your lungs, and emphysema will kill you pretty much as effectively as cancer will if it's severe enough, in a very painful and suffering way. And so cigar smoking, cigarette smoking, pipe smoking, hookah, ganja even, because the cannabis leaf is a plant, and when it is combusted and burned, similar chemical elements are released as when burning tobacco. And although we don't have as much data on the association, the direct association between smoking marijuana and getting cancer, all the evidence is beginning to show that smoking marijuana leaf, it increases your risk for the development of lung cancer. Chewing tobacco. Some people say, "Oh, I won't smoke it, I'll chew it." Well, yes, that will take away a lot of your risk of lung cancer because you're not inhaling the products, but the risk of mouth, oral cancer, throat cancer, esophageal cancer are all increased in chewing tobacco users. So, you know, we cannot justify the use of tobacco in any way. And it is really a societal shortcoming, and I would go as far as to say a crime to continue to allow tobacco to be sold to people. If we are going to put people in jail for selling marijuana and selling cocaine, well, tobacco is responsible for many, many more deaths and suffering than either of those two things combined. And it is just a travesty that people still are able to go and buy tobacco and smoke it. It's wrong. It's cost the society billions of dollars worldwide every year to deal with the consequences of tobacco usage. And the only reason that it's still being sold is because people make money doing it. And that's the only reason. I have a very strong aversion to tobacco as a product, and I really have a hard time understanding why tobacco usage continues to rise in some parts of the world. And it's due to advertising campaigns and due to continued glamorization of this most unglamorous and filthy habit. And so I just don't understand why we cannot get a handle on it. If we were able to, we wouldn't be talking about lung cancer very frequently the way we have to nowadays. That's my little rant on tobacco, but I could go on for hours more, but we'll keep going. And again, how unfair is it for you who do not smoke to have your risk of lung cancer increased significantly by breathing in the smoke of others? And we now know that is unequivocally true, that if you breathe in somebody else's smoke, your risk of cancer can go up significantly. And if you breathe in enough on a frequent basis, such as somebody who lives in the same house as a heavy smoker, your risk can be up to 10 times the general population's risk of developing lung cancer. Some other lower frequency risk factors include radon gas. Now, radon gas is a naturally occurring radioactive gas occurring from the breakdown of uranium in soil and rocks. And there are parts of the world where there's a high percentage of uranium in the soil and rocks. Hence, those are places where uranium is mined. Now, the thing about it is you cannot see, smell, or taste radon. And so you may not know that you're being exposed to radon. And radon may be the second leading cause of lung cancer worldwide. We don't know for sure. And it may be one of the implicated causative factors in non-smokers who develop lung cancer. But there are huge geographical variations in the incidence of this type of exposure to this insidious radioactive gas. And we're still working that out, although there are people who believe that there's more knowledge about this than is being released to the public because of the difficulties that would arise from relocating huge populations from areas where radon gas exposure is high. So it's great fodder for the conspiracy theorists out there, but it is in fact a real thing that we have to start to taking seriously in some parts of the world more than others. The Bahamas is not known to have any such geological formations that would increase the exposure of the population to radon gas. But other countries like Russia, Canada, China, and the United States, they have significant areas where radon gas exposure may be higher than was previously thought. Asbestos is thankfully not as common in our society as it used to be. It used to be used almost in every building as soundproofing, or in roof, in ceiling tiles, or as insulation for electrical wiring or plumbing. And therefore, for many generations, a lot of people were exposed to asbestos. Asbestos is a naturally occurring mineral, which was found to be very useful because it doesn't burn. So you could use it as fireproofing and insulation. But the problem is it sheds off microscopic fibers, which when inhaled into the lungs, elicit a reaction that in many cases led to development of cancer. Most cancers that are known as mesothelioma, which is a type of cancer that can occur in the chest and the abdomen, were caused by asbestos. But asbestos most often also caused squamous cell, non-small cell lung cancer as well. So asbestos exposure has been decreased significantly due to regulation, but we still come across people who have been exposed in the past to asbestos, such as people who worked in shipbuilding or ship maintenance or shipyards where they used to break down old ships that were full of asbestos insulation, or people who worked in construction industry, especially in demolition, where they would be demolishing old buildings that had a large amount of asbestos in them. These people still turn up with types of lung cancer, including mesothelioma, and we still have to be aware of it. Again, arsenic in the drinking water is a geographically variable risk factor and may be associated with development of a number of different cancers, including lung cancer. Other things that could be exposed, obviously radioactive minerals like uranium. Radiation exposure is known to cause all different kinds of cancers, leukemias, lymphomas, and cancers of the lung, skin, bone, etc. Inhaled chemicals or minerals, such as in this list, which some of them are in car exhausts, some of them are in diesel exhaust. And I mean, if you've ever been on a boat that's running a diesel engine and you get a whiff of that exhaust smoke, you know that's not a good thing for your body. And we know that there's a lot of different elements and combustion products in car exhaust and diesel fumes that are dangerous and are potentially carcinogenic. And there's a number of other things such as beryllium, cadmium that we may be exposed to and not even know it. And those are implicated in development of a number of different cancers, including lung cancer. Now, unfortunately, and this is something that causes confusion in patients sometimes when we send them for radiation treatment for cancer. So radiation therapy is a part of treatment, especially of advanced cancers of various types. But of course, radiation does carry a risk of the development of other cancers in some situations years after the radiation therapy may have occurred. It's difficult to quantify, and it has to be said that radiation therapy in the last 2 decades has become much safer and much less likely to induce the development of a different type of cancer than the one you're being treated for. But there is a definite association with radiation therapy and the development of cancers in years following that treatment, especially if that therapy was given to a child. But we must remember that in many cases, the radiation is necessary to cure or control the original tumor. And the development of radiation-induced cancers is not common, but it is not zero incidence. If you have a history in your family of lung cancer, well, this may indicate a genetic mutation in your family line that puts you at more risk for developing lung cancer if you are exposed to a trigger such as cigarette smoke or radon gas or any of the other risk factors like beryllium or chromium exposure or any of these other things. That could act as a trigger if you have the genetic tendency in your genetic makeup. And so that is where we started to realize that there's a genetic component to cancer. It's not just the environmental trigger. The trigger has to have something to act to respond to the trigger. So genetics is important. And I spoke about the car exhausts. You know, there are communities that exist, especially in Asia and North America, where they're sort of surrounded by freeways and highways, and on all sides is a major road, and these communities seem to be trapped within these trapped by these large roads surrounding them. And it has been shown in many of these communities that the incidence of lung cancer as well as other conditions, medical conditions, are increased. And it may be due to the high amounts of air pollution that the people in these sort of trapped communities may be inhaling. How do we treat lung cancer from a surgical point of view? Now, I'm a surgeon, so I'm going to start with that. And truthfully, if you get lung cancer early, the way to treat it is surgical, which is to remove it. And we have various types of removal procedures, from just removing a segment of one lobe of a lung. This is the right lung, which is upper lobe, middle lobe, lower lobe. The lower lobe is actually much larger than that. It extends posterior into the back, so it looks small from the front, but it's actually very large. But if we take a piece of one lobe, we call that a wedge resection. That's the least common way of curing a cancer, but sometimes if the cancer is very small, that can cure it. More often, we would take an anatomical segment, which is larger than a wedge, or an entire lobe. For example, in this case, we've taken the entire lobe, the upper lobe, or we might even take out an entire lung. Now, the thing is, you have 2 lungs, and if your other lung is relatively healthy, you can live quite comfortably with only 1 lung. So the most radical procedure we can do for trying to cure somebody of cancer is what's called a pneumonectomy, which means removing 1 lung. And even though this operation removes the most of the lung, it's the technically easiest one to do. Imagine a tree, and if I cut down the tree at the first largest branch, as opposed to having to climb up into the tree and cut only a small bunch of branches at the very top of the tree. Obviously, that might be more difficult than cutting the tree off near to the trunk. And so actually pneumonectomy is technically simpler than other things like a lobectomy or a segmental resection. But it does remove the most lung tissue. It also removes a fair amount of normal lung tissue, but sometimes the pattern of the tumor requires us to do that. I won't get into the details, but sometimes a pneumonectomy is the appropriate thing to do, even though we're taking some what looks like normal lung tissue. If we can remove that lung and the cancer, that may be able to cure the patient. The conventional form of surgery is open surgery, and it's still the most common approach. This is actually a photograph from, I believe that might be my hands doing this operation one time years ago. And we have the patient's chest open, and we're looking inside the chest cavity. This is the forceps holding a piece of the lung. We're putting in sutures around the blood vessels to take out that piece of lung. That's still the most common approach. It's still the most widely applied approach worldwide. Other things are gaining prominence in some of the more technologically advanced jurisdictions, such as Europe and North America. This is video-assisted or thoracoscopic surgery, where the principles are the same as with open surgery, but you're going in through small incisions, putting instruments inside, and the surgeon watches what's going on by controlling the instruments by his hand from on a monitor screen. And that's an increasingly common way of doing some forms of lung cancer. Not all, you still have to do open from time to time. And then the most recent development is this sort of space age thing called robotic surgery. So here's the patient, here's the nurse, here's a robot. And here are two surgeons, a primary surgeon and an assistant surgeon, and they are controlling these robotic arms and looking at what's going on inside. And the robotic arms are being controlled by the two surgeons, one holding like a retractor and the other one doing the actual dissection, etc., using these robotic arms inside, where the robotic arms are somewhat similar to the instruments that these guys are using. But instead of actually holding them themselves, the robot is doing it, and the surgeons are not even scrubbed in. They're not even they didn't even have to wash their hands basically to do this operation. So that's the way it's starting to go in some areas. This machine, for example, to purchase it right now, the cost is approximately $3 million US just for the machine, all this stuff. And so it's not widely applicable to most of the world, but just to be aware that in some parts of the world, and not even all parts of the developed world, robotic surgery is being performed in some cases. And just to show that we are, as developing world people, we can participate in some of these things. This is a simulation of a robotic surgical procedure using one of the types of surgical robots on a mannequin. This is the mannequin. This is a simulation environment that I helped to develop in North Carolina at a company called Kind Heart, where now you can practice robotic surgery on realistic tissue-based simulation. These are actually pig tissues, which we animate to look like it's alive. So there's a beating heart in there. It's not really alive, but it beats similarly. The lungs can inflate with air. There's blood flowing through, simulated blood flowing through the blood vessels. So somebody can practice and learn how to do a robotic procedure. And just to show that even though we don't do that here, we can still be involved. We being the Caribbean, the developing world, we can still have a role to play in some of these advancements. Maybe not locally doing the surgery because the equipment is so expensive, but not really completely out of the loop. And then you have other ways of treating lung cancer, such as chemotherapy and radiation therapy. So surgery, chemotherapy, radiation therapy, they may all be used either individually at certain times during the course of the treatment, or combined therapies can be utilized. And what I have said that chemotherapy and radiation are more common in advanced disease, where you may not actually be able to cure it with surgery, or in that very aggressive small cell lung cancer, which it tends to be advanced at the time of discovery. What can you do to prevent lung cancer? Well, what do you think the first thing I'm going to say is? Obviously, the first thing I'm going to say is don't smoke. Okay? There are some things that everybody can do to reduce their risk, there's no surefire way to prevent lung cancer, because as I said, there are certain people who get lung cancer who have no risk factors. And as of yet, there may be a risk factor or a reason why they got it, but we have not yet discovered that. The best way to reduce your risk of getting lung cancer is to not smoke cigarettes and to avoid breathing other people's smoke, which means if you go into a club and it's full of smoke, go find some place to dance. Being in that club is not worth you breathing in everybody else's cigarette smoke, because it does increase your risk. Even that one exposure has been shown to potentially increase the risk just a little bit of developing lung cancer. So no exposure to cigarette smoke is safe. No exposure to anybody else's smoke is safe, and you must not put yourself in that situation. You yourself must not smoke, and you must not breathe other people's smoke. That's one of the best ways to avoid developing lung cancer. I get angry when I think about it. I don't wait. Excuse me for getting upset, but the whole thing about smoking is just an inexplicable thing to me, why we still have this in our society. So in some places where radon gas is known to be a problem, they have people who come around on regular inspections to check for your level of radon gas in your environment. We don't seem to have it in the Bahamas. It has been tested intermittently, like many decades ago. Radon gas was tested in certain parts of the Bahamas and they didn't find any. So since then, I don't know if they've done it again. But in some places in the world, it's almost a regular thing. Once a year, somebody will come in and take a reading. And if it's persistently high, you better move. You should not expose yourself to benzenes and other oil-based chemicals that can be absorbed through the skin, are known to cause an increased risk of cancers, of many different types of cancers. If you eat a healthy diet rich in fruits and vegetables, your risk of cancers of all types will go down. One of the reasons is that fruits and vegetables contain a lot of chemicals that counteract the effects of some of the known carcinogens. And so a diet rich in fruit and vegetables, low in red meats and saturated fats, is known to increase your resistance or increase the population's freedom from the development of cancer, let's say. Okay. What is lung cancer screening? Screening is an approach to looking for cancers in people who have risk factors, so we can catch the cancer early and intervene before it becomes an advanced situation, which is not curable and which will probably eventually, even if we have good treatment, lead to that person's death. So we want to catch it before then, and that's what screening programs are. So the American Cancer, sorry for this slide, the American Cancer Society's guidelines for screening as of 2018 says that if you have all of these following criteria, you should be screened for lung cancer, definitely. 55 to 74 years of age, and you're in fairly good health. In other words, we're not looking, if you have somebody who's cachectic, that means they've lost a lot of weight, they have no appetite, they're coughing up blood, they have lymph node enlargement, that's not somebody you're going to be screening for cancer. That's somebody that you're looking for the cancer that's there. We're talking about somebody who seems to be in good health, and you're trying to make sure that there's nothing going on before it becomes apparent. So if they've been a current smoker, if they are a current smoker, or if they've smoked up to 15 years prior, if they have a 30-pack year history of smoking, which means they smoked a pack a day for 30 years, or the equivalent. Sometimes it's 2-pack a day for 15 years, for example. That's a 30-pack year history. If you have a 30-pack year of history at any point in your life, even if you quit 20 years ago, you fall into this category of people who should be screened. Now, if you've received counseling to quit smoking, but you're still smoking, that's a red flag that you need to be looked at as a possible person who may have an early cancer. These are last, don't worry about these. These are technical issues where you have to have a place where you can do the screening. What does screening involve? You need a certain type of CT scanner, a low dose CT scan needs to be done. We don't want to expose people to high doses of radiation unnecessarily. And it has been found that if you use a low dose CT scanner, meaning a low radiation intensity scanner, it can pick up early cancers in many people if you do the study correctly. If you do have to have a team of specialists that look at the results, to look carefully, much in the same way that as mammograms are interpreted by experts who look at mammograms all the time looking for breast cancer. So you have to have the setup to look at the scans once they're done. If you think you have the risk factors that put you at high risk for lung cancer, then you need to take the initiative and talk to your healthcare provider about what is the need potentially for getting screened and how can it be done. And you need to know that screening is not perfect. There are limits to screening. It will not pick up cancers of a certain small size, and it will not pick up even all cancers of the threshold size that it says it can. Nothing is perfect in a man-made machine, and CT scanners are man-made, so they're not perfect, but they are an incredible tool for helping us discover early cancers. And of course, lung cancer screening is not for free in most cases. A CT scan is an investigation that costs money, but in many cases, if you have a really good insurance policy, it might be covered if you have the risk factors. If you have the risk factors, if you're a smoker, et cetera, and fall into some of those other categories, 55 to 74 years old, you may be able to get your screening CT scan paid for by your insurance. And if you remain at high risk, and for example, you keep smoking, you smoked heavily until age 55 and you still smoke intermittently, you may need to do that scan every year until the age of 74, after which, especially for men, you're approaching the sort of expected lifespan anyway. So the benefit of continuing to screen versus what will happen to you if you do develop the cancer after that age start to converge. And so that's why they stop the recommendations at age 74. But you may need to keep doing that once a year. This may involve travel, and if you don't live near a facility that can do these screening examinations. And of course, screening is not like a get out of jail free card where you can keep smoking all you want just as long as you keep getting screened. It is not an alternative to stopping smoking. It is only going to pick up the cancer once you've got the cancer, and therefore you are still now in a bad situation where you have cancer and you need to stop smoking. You must try to quit smoking. You must get help if necessary, and help does exist even in different jurisdictions. Help does exist to try to help you to quit. There are medications you can take. There's nicotine gum you can chew. There are groups that you can join that will help support you in your quest to stop smoking. If you gain a little weight, that is okay, because that's not as dangerous as smoking cigarettes, and that is usually temporary anyway. People say, oh, I don't want to stop smoking because I'm going to gain weight. Well, that's not a good enough excuse to continue to expose yourself to one of the most potent inducers of cancer that has ever been devised, which is the cigarette. And as I said, some people, they don't have any risk factors. I really, really feel for people who don't smoke, who've tried to be healthy, and yet they develop this cancer, and they develop it, and it almost always seems to be highly aggressive and grows rapidly and spreads early, even if it's a non-small cell. These are very, very sad situations that we still see, and we are still searching as a medical fraternity and sorority. As you know, most doctors are nowadays female, so I suppose calling it the medical fraternity is an anachronism. We should start calling it the medical sorority. But most of these people will have an aggressive form of the treatment, and we're trying to figure out what is the trigger that led to this type of cancer. It would appear at this time that we're going to find out that it's a genetic predisposition, and the trigger may not be as clear-cut as cigarette smoke. It may be something that as yet we haven't really associated with the development of cancer. We do believe as a medical sorority that one day we will find out what is causing these cancers. We're not there yet, but that's where organizations like the Cancer Society of the Bahamas and other cancer societies around the world will help by continuing to provide funds for research, by providing support for cancer sufferers, so that we can help them the best way we can, and eventually get to the point where we can know what's causing all these cancers that are not associated with cigarette smoke. And that's all I really have to say about it at this time. I hope that it has been a bit educational. I'm sorry if I was a little bit emotional about the cigarette smoking. Believe me, I can get a lot worse and more emotional than that when you're talking about cigarette smoking. But I don't think, speaking to a Cancer Society audience, I have to convince anybody of how bad cigarettes are. So thank you so much for giving me this opportunity to present this this very important topic to you. And if there are any questions, I'm happy to take them.
Are there any questions for Dr. RAMPHAL? Well, Paul, very nice talk, and thank you. Well presented. In your practice here in the Bahamas, compared to say Jamaica, have you seen the numbers of lung cancers or equivalent?
You know, one of the things that I can only tell you, and this is the worst type of evidence, which, as you know, is anecdotal evidence.
Anecdotal, yes, but
yeah, based on your experience. But I get the impression that lung cancer is more common in the Bahamas per capita than it was in Jamaica, for example. Certainly, certain population subsegments of the Bahamian society, such as the Bahamians of European origin, a high percentage of them smoke, and it's very discouraging to me to see how many Bahamian people, especially let's say the white Bahamian population, smoke cigarettes.
I just look back at some statistics from the registry that Dr. Francis gave me. We had in 2018, we had 184 breast cancer patients. We had 64 prostate cancer, and only 16 lung cancers. So those numbers are a bit skewed because it doesn't pick up everybody, because not everybody comes through the public system.
Well, you see, we have a much more robust and well-established prostate scans, breast cancer screening program. Mm-hmm. And the population is much more aware of what to do and how to pick up a breast cancer with self-examination and etc. Mm-hmm. We have a prostate cancer, even though that is resisted by a large percentage population, we still can pick up a lot more. And of course, those are both accessible to the hand. So you can feel a prostate cancer with a digital rectal examination. You can pick up a breast cancer early lump by examining the breast, but it's very hard to examine the lung. You need something like a CT scan or a chest X-ray. And I'm sure that a large number of people have lung cancer, or maybe even die of lung cancer without ever even knowing it, because they don't go to the doctor for it, or they don't get a chest X-ray, they don't get a CT scan, etc., to prove it, etc. But in terms of registering it in the registry, I can't explain that so much, but except to say that most of those cases would probably not have been picked up. the way you
another question. You you mentioned smoking ganja. You know, the rules of smoking ganja is going to be pretty relaxed soon. But you had a lot of ganja smoking in Jamaica. But you may see a rise, I guess, in the young folk who go and use ganja. So we still need to push stop smoking and using of these illicit drugs, I guess, at some point.
Absolutely, because as I said, it's not the marijuana, it's not the hallucinogen or the stuff that makes you high that's the problem. It's the burning of the plant material releases carcinogenic chemicals into the smoke, and analysis of tobacco smoke and marijuana smoke reveals many of the same types of chemicals. And so we can infer that you're putting yourself at risk when you smoke it in a similar way to when you smoke tobacco.
One other question. I don't see any questions on the chat, but in terms of treatment, in terms of chemotherapy, drugs, and the new biologics, has been a lot of new stuff on the market for those things?
Yes, there have been a fair number of drugs. So many that actually I can't keep up with them. Yeah, and I leave that to the oncologists for the the most up-to-date combinations of treatments. But put it this way, I have seen people who a decade ago I would have said when I biopsied their tumor, in my mind I would have said, boy, this person has got 6 months to live at the most, and I see them lasting 2, 3, 4 years. Based on these new chemotherapy regimes that are available. So that's very, very encouraging and very, very wonderful. And I think many other cancers have seen a similar change in their, in their results, survival and quality of life survival has increased a lot. And that's great. And that's what we have to thank the various oncological medications for.
Any more questions from the audience? Are there any more questions from the audience? Well, Dr. RAMPHAL, I thank you. Very interesting talk. A few more announcements. I wanted to leave it to the end because I know people will filter in and join the meeting. The Cancer Society still has a lot of events coming up in the next few weeks or so. We have our auction, which is going to be done on November the 20th, Wednesday. I got the right date. November 24th, I think. And you can access the items that are being auctioned on localbahamas.com auction. Also, we're going to have a Stride for Life Run, Fun, Walk again this year. And that's going to be on the 20th of November. And our Love Lights a Tree ceremony at Marathon, where we erect the Christmas tree and have an event there at the Marathon outside Kelly's. It's on the 26th of November. We also have to promote, I think Aaron put up did you put up the sign? Yeah, No Shave November, where all the proceeds will come to the Cancer Society. They're encouraging men to not shave their beards or mustache for the month of November and contribute to the Cancer Society of the Bahamas. There it is, virtual auction and the virtual walk. Virtual auction is November the 24th, Wednesday. But as of tonight or tomorrow, you can see the items being auctioned on that local Bahamas site. Aaron, did I miss any announcements? I can't remember.
No, that's about it.
Love Lights a Tree.
Yes.
Okay. If there are no other questions, go ahead. Sorry.
But for the auction, you go to bahamaslocal.com, and there you can see the pictures of the items that are up for bid.
Right.
So you don't go to the Cancer Society website. You go to www.auction.bahamaslocal.com/auction cancer-society at HTML. And there you can see all the items. You can pre-bid, or if you want to buy it right out, you can buy it now. but most of the photos are up. I checked the site and most of them are up, and more things will be continued. So the bidding will begin tomorrow, November 10th, and it goes until November 24th.
Okay. If there are no other questions and comments, we could call it an evening. Again, thank you all for listening and joining us tonight on this virtual monthly meeting. Good evening.